All right. Hello and welcome to Ask Your Doctor. This is an informative health session that is sponsored by My American Doctor. They are a group of highly trained and experienced doctors that represent all specialties and provide second opinions throughout the country. We are not here to give individual health advice or treatment plans, but just to give a general idea of certain conditions. If you still have any questions or need further clarification, you can go ahead and get in touch with us. We do have the live audience watching us today, so if you have any questions, feel free to ask. If not, go ahead and visit our website at MyAmericanDoctor.com or go ahead and give us a call at 919-914-941-494 to book a second opinion consultation with one of our specialists. Today, we have the privilege of speaking with one of Kentucky's leading experts in cardiac care, Dr. Keerthy Narisetty. He is an advanced heart failure and transplant cardiologist at St. Elizabeth Healthcare in Edgewood, Kentucky, and brings over 22 years of experience in medicine. His extensive training includes fellowship programs in cardiology and advanced heart failure and transplant cardiology, with clinical work at top institutions such as Emory University and Michigan State University. Throughout his career, he has focused on treating some of the most complex heart conditions, including heart failure and end-stage cardiac disease. In today's conversation, we will explore the causes of ischemic heart disease, how it can lead to heart failure, current treatment options that are available, and even the latest advancements in heart transplant care. Dr. Narisetty, thank you so much for joining us. How are you doing today?
I'm good. Thanks for the opportunity, Ariana. It's a pleasure to talk, and really, it's my life goal to educate people and help them to navigate this complex disease process. So it's been a pleasure. I've been in practice for like 20 plus years, and I still feel that there's a lot to learn in this field, and this field is evolving, and especially the heart failure and transplant world has kind of opened up a lot of new avenues and things like that. So it's a pretty evolving field. Although we have done, we have dealt with heart failure and transplant for since the 1950s. We still feel that field is new and it's growing, and it's a lot of potential to grow as well and help a lot of patients. Uh,
Yeah.
as you said, the reason why we keep talking about heart disease. I mean, it's a very prevalent. If I
Mhm.
have to put things in perspective, heart disease is number one killer in the world, especially in the United States.
Yeah.
Um, Based on the statistics we have, there is every death that is attributed to heart disease every 34 seconds.
Oh, wow.
That's a lot. Um, and if you look at the economics of the disease or the disease burden, it's $250 billion plus. So
Wow.
a lot of people are dying, a lot of people are
Yeah.
struggling, a lot of people are suffering. So we need a lot of work to do, a lot of things to change and to catch up with. So that's why I think heart disease is a priority. I would say, not only in
Yeah.
US but also in the developing world. I see. Although I practice in US, I keep in touch with my colleagues back in India and in Middle East. Um, the thing that I hear is that there's a lot of growing cardiovascular burden over there. In fact, the cardiovascular disease in India has doubled from the 1990s to now, which is going to be a lot more if you consider the population in the subcontinent. So
Yeah. Wow. Well, we appreciate your passion in this field here. We appreciate all the insights we know you're going to bring to us today. So let's just kind of start with, in the simplest terms that you can give us. Can you explain what heart disease is, what ischemic heart disease is? Let's kind of just start there.
So I think ischemic heart disease is the number one cause of heart failure. So that's why, um, you know, kind of wanted to focus a little bit on that. So to put it in a simple perspective, ischemia is lack of oxygen. So when um, you have there are three arteries which sit on the top of the heart, which we call as a corona. So when you have narrowing of these arteries, which is called coronary artery disease,
Mhm.
um, it deprives the cardiac muscle, the heart muscle, of oxygen. So anytime you're
Mhm.
depriving the heart muscle of oxygen, you start seeing people having symptoms. They develop what we call ischemic heart disease.
Mhm.
It is the number one cause of heart failure, and number one, I would say, preventable cause as well. If we can identify the causes or go to primary prevention. So um, as you know, heart is a very fantastic muscle. I mean, it keeps beating for 100 plus years, right? You need oxygen for that, and that oxygen is supplied by the arteries that take the blood to the heart muscle, and these called coronary arteries. So anytime you have a narrowing or a blockage, which deprives the heart muscle of oxygen, you have what we call a ischemic heart disease.
Okay. And is that something that you're born with? Does it develop over time? What really causes this condition?
Fortunately and unfortunately, not. We can say both because um, based on the Interheart study, there's a genetic component. So you probably can inherit some things from your parents, but most
Mhm.
of the causes for ischemic heart disease are preventable. One of the number one causes high blood pressure. There is hypertension, right?
Okay.
High cholesterol, diabetes,
Mhm.
lifestyle. I mean, if you are living a sedentary life, that's going to be a problem.
Yeah.
Obesity, these are all, and smoking. These are all some of the top causes of ischemic heart disease. Now,
Mhm.
genetics is something that you can't prevent, but the rest of them, I guess, probably you start working on it. Try to get to down to the underlying cause that you can prevent, and you can prevent the ischemic heart disease by trying to be active, trying to check, get your blood pressure done, go to your preventive care, go to your family doctor once a year, check your
Yeah.
blood pressure, check your cholesterol, check your glucose. So these are all preventable causes, but these are common causes for ischemic heart disease.
Okay. Yeah. And how does ischemic heart disease then affect the heart's ability to function properly?
So as I alluded to in our in the earlier part, like when you have ischemic heart disease, that means you have blockage. So your heart is a workhorse, right? It's working all the time. It beats
Yeah.
at 70 times a minute. It's a heavy muscle. It needs oxygen. So when you deprive the muscle of oxygen, that's when you start seeing that the muscle gets damaged. So you
Okay.
want to make sure that you don't have blockages. One, there are several other causes of heart failure, but ischemic heart disease is the number one cause, and that's how you slowly start seeing, like, say, people who don't pay attention to the symptoms, people who think that, okay, I'm having chest pain here and there. So you want to be attentive to the symptoms and reach out to people. If you have high blood pressure, if you have family history of high blood pressure, if your
Yeah.
regular screening test show that your glucose levels are high, you probably might be started to have diabetes at that point of time. So
Yeah.
you want to make sure that you address those causes that can be prevented.
Yeah, of course. Yeah. And so does this typically lead to then like heart disease? Like what does that kind of progression then look like for the heart?
So when you have blockages, so always your heart is demanding and you're not able to meet the demand. So as a
Mhm.
muscle, because you're not providing that, we see a damage. So the heart gets weaker and weaker, right? And that's when you tend to go into heart failure. If we identify them early, sometimes, again, fortunately, unfortunately, if the blockage happens all of a sudden, people come with heart attack. So
Mhm.
obviously, we have a very good STEMI program throughout the US. We have what we talk about a door to balloon time. So when they come in, we have 90 minutes. So once they hit the ER, you do an EKG, you see ST
Yeah.
elevations. That means that the blood supply to that part of the muscle is cut off. You take them to the lab and open up the artery and put a stent. Or if they're having multiple blockages, then you talk about possible coronary artery bypass surgery. That's called, the common term that we use is CABG. So you want to identify it early on so that the muscle doesn't have an irreversible damage. When irreversible damage happens, that means that you don't pay attention to the signs that you're having. You ignore, or say, a lot of times I see patients who had chest pain, like, again, it's not their fault. Sometimes they have atypical chest pain. They
Yeah.
consider that, oh, I had heartburn like, you know, 3 nights ago. It was
Yeah.
burning very. It's kind of there for like 4 or 5 hours. I felt uneasy, and then they don't show up, and then a week later they come with heart failure. So those
Yeah.
are things that we want to educate people on, so that if they have risk factors, if they have symptoms like that, they need to present. Because if we identify the process early, if we know that they have a blockage, whatever, if someone is a diabetic and having atypical symptoms, right, not typical
Yeah.
chest pain, they have very atypical presentation. That means that they don't have a classic chest pain like the crushing chest pain. They might just feel fatigue, they might have some shortness of breath. So we can identify those by doing a stress test. Once we identify the ischemic heart disease with stress test, we do things to see what we can help them, whether they need revascularization. That means that having retaining the blood flow to the heart muscle, right? By either
Yeah.
placing stents or by doing a bypass surgery, whatever it takes to restore and prevent further damage from the heart muscle. The problem happens is when they don't come, and then when the repeated insult happens, and when we
Hmm.
come to a point where the muscle is necrosed, at that point, they end up with heart failure, and
Yeah.
that
Yeah.
might be more or less irreversible at that point of time.
Yeah. When we talk about kind of these symptoms, kind of chest pain, either typical or atypical, what other symptoms are we to look for then, that kind of give us a sign that we need to go get checked out?
So in medical school, the first thing that we tell is, when someone has chest pain, like, you're worried about the heart. So that is a very, what we call a bookish symptom, right? You have a
Yeah.
crushing chest pain in the center of the chest, and then it might go to the arm, to your neck. That is the classic description.
Hmm.
Um, in females, in people who have diabetes, the symptoms might not be very classic. They can have
Yeah.
profound sweating, like, they say, okay, I'm not doing anything, I'm sitting watching TV, I'm just drenching in sweat. That's something
Yeah.
wrong. Or
Hmm.
there's something going on that we can't explain that because it didn't happen in the past, right?
Yeah.
You have this jaw pain, which is not very unusual. Sometimes people come with jaw pain saying that anytime I do something exertional, that means that I'm walking and taking a flight of stairs, I start having this jaw pain.
Yeah.
Well, that's a sign that's very atypical, but again, you need to pay attention to that.
Yeah.
Sometimes people have palpitations, that their heart is racing fast. um, Fatigue, like, when you're doing things that you were used to doing, and all of a sudden, you know example is, like, I see people who come say, what, I can do like 3 4 flights of stairs without a problem, but
Yeah.
last 2 weeks I take a flight of stairs and I'm done, like, I'm not,
Yeah.
I feel like I'm exhausted, right? Which is not a usual thing. So those are the kind of unusual symptoms that we need to pay attention to, especially
Yeah.
if someone has a predisposing factor, or if they have risk factors, like, if, if someone is a smoker, or someone has high blood pressure, has a
Yeah.
family history, premature family history of coronary artery disease. If they have symptoms like this, I would be calling my primary doctor to see what's happening, and then get checked.
Yeah, yeah, yeah. So we have these patients, they come in with these symptoms. Let's say they're diagnosed then with heart failure, heart disease. What are the main treatment options then? What is the next step there?
So, so you have, say, unfortunately, you get diagnosed with heart failure. There are
Mhm.
two kinds of heart failure that we have. One is systolic heart failure, diastolic heart failure. For
Mhm.
lack of time, I would don't want to go into the nitty gritty of that or details of it. But say if you have heart failure with systolic heart failure, that means heart failure with reduced ejection fraction.
Yeah.
Um, the symptoms would be, people start seeing swelling in the legs, or
Okay.
they can say, I feel tired, I feel exhausted, I feel fatigued, I can't carry on my day-to-day activities, I see my
Mhm.
legs swollen all the time. Or when I sleep, you know I'm not able to lay flat, or they say I
Yeah.
need to use like 4 or 5 pillows to prop my head up, or I'm waking up in the middle of the night gasping for air, trying to open
Mhm.
up the window to get a fresh air. So all these are symptoms of heart failure. So at this point, your heart muscle is damaged because your heart is not able to pump enough blood,
Yeah.
and what's happening is it backs up into your lungs, it backs up into your um, systemic vasculature, and you end up
Mhm.
retaining fluid.
Okay.
Um, is that the question, or?
Yeah, yeah. And so what are the treatment options then for that? Is it medication? Is it kind of lifestyle change that you urge these patients to take? What's kind of the route then that's next?
Right. So it's a very comprehensive thing. And the reason why I went into heart failure is you can have a very complex patient who you need to work with from right from the bottom, right?
Yeah,
A lot of people with heart failure, they don't understand the lifestyle. The lifestyle changes makes a lot of difference. One is um, I ask them to religiously check their blood pressure every day, check their weight, um, you know, watch what they're drinking, because when you have heart failure, your heart is overloaded. It can't take much volume. So I ask them
yeah,
to restrict their fluid intake to 64 ounces or 2 liters a day, which is a lot more challenging because people are used to drinking a lot, right? I mean, when you have a
yeah,
normal heart, we have we don't have very strong data, but there is a data to show because and then salt. I ask them to look what they're eating. I
yeah,
encourage them to eat fresh if it, at all is possible, or if they go to the aisle. That's why we have a very comprehensive clinic where it's not only me, but I
yeah,
have a dietitian with me. I have a pharmacist with me. I have a social worker with me because I need to figure out what in what way I can help them. I mean, a lot of people can't afford, a fresh diet. So, is there a ways and means that we can help them to encourage them to, there are dietitians who take our patients to the aisle and show them how to look at the sodium content in the diet.
yeah,
Unfortunately, the diet that we eat today is not a healthy diet. So they have to pay attention to that. So lifestyle changes are some of the things that needs a basic education. But I have seen people, the best advantage of lifestyle is people who have heart failure, they go on to retain fluid, and that's what
hmm,
makes them symptomatic. So they retain fluid in the body. Once they retain fluid, it puts a lot of stress on the heart, and
yeah,
that's when they have symptoms, and that's when they
yeah,
come to the hospital. So your quality of life is gone down because you have symptoms. Your quality of life goes down because you come to the hospital regularly. So if we identify these factors and try to see
yeah,
how we can prevent that, that's a great opportunity for us.
yeah,
There are a lot more medicines. I mean, the field, 10 years ago, we used to have like maybe two or three medicines. Right now, we have a wide variety of medicines. So we
yeah,
call them as four pillars, or guideline directed medical therapy. And these are basic medicines that have been there around, but there are some new ones that they've added to the mix, and they make a lot of difference. Like
mhm,
I have to explain to you a common man level. I say when you have heart
yeah,
failure, your body is like under stress, and
oh,
when your body is under stress, your neurohormonal system gets activated. So anytime your neurohormonal system gets activated, it demands more of your heart. it's a
okay,
it's a response, right? It's a response for your weak heart, because it wants your heart to beat faster, beat a little more stronger. But because your heart function is down, your heart is not able to keep up with that in the long run. So you
yeah,
need these medicines to what we call check this neurohormonal system. So they
okay,
help to rest and heal the heart. And I've seen many a times people who have both ischemic and non-ischemic cardiomyopathy. That means that people who don't have ischemic heart disease, but there are several other causes for heart failure. With proper medical treatment, you see that heart function restore or get better.
oh wow, that's
Or
awesome.
even if the heart function doesn't get better, they actually have a good quality of life. They don't have issues with fluid retention and things like that. So that's medical therapy, right? And there is all more excitement in the last 5 years about the device therapies. I mean, a lot of devices have come up. I think we still need more studies to that, but some of the early studies that we've seen have actually shown to improve quality of life. That means that people are able to do more, walk more, feel better. So these are the things that they are focusing on. So there are device therapies that are available, which includes, what the device therapy that we have right now is MitraClip, cardiac contractile demodulation, Barostem, intraatrial shunt. So there are variety of things that are available that we can choose from, and
Mhm.
it all depends on where the patient is and how they're doing.
Yeah. So are those device therapies, are those like pacemakers, like defibrillators, things like that?
So pacemakers are something that we use when we see that the heart is not in synchrony. We
Okay.
go by certain criteria. They do help. Um, of course, with the medical therapy, with the background of medical therapy, pacemakers will help.
Yeah.
Defibrillators are not so much. Defibrillators actually, they are more like a safety device. So once you have systolic heart failure with your ejection fraction, that means that the heart pumping ability is less than 35%.
Mhm.
We recommend the device, the ICD, that's called intracardiac defibrillator, that actually prevents sudden cardiac death. Um, it
Okay.
doesn't it doesn't change the course, but it prevents you from having a sudden cardiac death.
Yeah. Yeah. So we talk about these medications, these maybe device therapies. Do you ever recommend then surgery for someone who is diagnosed with this?
With heart failure, yeah. So
Yeah.
our goal is, as a advanced heart failure cardiologist, our goal is to focus on the quality of life. We work with these people very closely. It takes a village, what we call, with our pharmacists, trying to improve the compliance, trying to change the lifestyle, medications. We are constantly monitoring them. We have devices, we have people in the office, we have a line of contact that we constantly keep in touch with them.
Yeah.
Despite all this effort, sometimes people progress. They progress to what we call um, advanced heart failure and end stage heart failure. So at
Yeah.
that, when they come to a point where the medicines, the devices are not working, I think at that point we start thinking about, um, do we offer something else? And we have a lot more to offer beyond this. We use something called IV medications. These are called inotropes. Um, they are constantly pumped into the body through the venous system, because these medicines, they need to be in the system around the clock because of the short acting nature of the medications, and they help improve the symptoms, but they don't alter the course.
Mhm.
And once we know that the patient is advancing to end stage heart failure, then we have a discussion depending on the criteria that if they qualify. We have a discussion whether they want to have a transplant or LVAD. Now,
Yeah.
when we come into realm, usually in US, the cutoff age for transplant is 65 to 70 years, give and take, based on the institution criteria. Some institutes, they have 65 years as a cutoff and 70 as a cutoff. So it depends on the institute. So if we see that they are beyond the cutoff age for transplant, then at that point we say there's something called a durable LVAD, left ventricular assist device. So if the patient qualifies for the criteria, we offer the device, right?
Yeah.
And the it all depends on what the patient wants, and how he perceives quality of life and things like that. And
Yeah.
when we offer somebody left ventricular assist device, which is a surgical option, right? It's called a destination therapy. That means once they have LVAD, um, they are married to it for the rest of their life.
Yeah.
If they're under 70 or under 65, and if we have institutions that offer, we offer transplant. But the limiting factor with the transplant is you have to wait for a donor heart, right? I mean, for a
Yeah.
LVAD, I can get it off the shelf, and the surgeon can put it in. But for transplant, we have to wait for a donor heart. Although there's a
Yeah.
lot of excitement in that field too, about how we're going to improve the donor hearts and things like that.
Yeah.
So
Yeah. I
yes.
think that whole idea has been always so fascinating to me. So what does that process typically involve? Then someone needs a heart transplant. Kind of, can you walk us through that, like what that process typically looks like?
So it's a bunch of work that's put into. So
Yeah.
sometimes it's overwhelming for the patients. I mean, honestly, when they turn up, you'll be seen by 6, 7 different people, right? They
Wow.
we if we come to a point where we think that the particular patient is ready for a heart transplant,
Yeah.
um, first of all, we have to run a bunch of tests, the what we call the imaging tests and the blood tests. And then they meet with our social worker, they meet with our pharmacist, they meet. We got to see how compliant they are, because compliance is the biggest factor. If they're not
Yeah.
compliant after transplant, we rely on the patient to take what we call immunosuppressants that actually prevents rejection. So if the
Yeah.
compliance is an issue, so we got to sit and talk and see what matches. Sometimes people say, well, you know, it's too much for me. I don't need transplant. But once we
Yeah.
figure out that the patient is ready for transplant, we get them through all the tests.
Yeah.
Um, then we say, okay, is he going to be once we know the eligibility for transplant, there's a
Yeah.
listing process that goes on. It's called a UNOS listing, right? When everything gets cleared and the patient is ready, we list him for transplant. There is a status 1, 2, 3, 4, 5, and 6. Um,
Okay.
Based on how sick they are, they go on the list depending on where they are. So most of
Yeah.
the times, if the patient is on IV medicines, which are called inotropes, and if they are functional and if they are able to carry on what we call the ADLs, that is activities of daily living, we let them stay home, and then we list them on status 4 for transplant.
Okay.
If we realize that they are declining or they're having more symptoms, then we slowly think about upgrading them, either by bringing them into the hospital and putting a temporary mechanical circulatory support, like we have percutaneous devices like axillary impellers, or we can put a VAD and then list them for transplant. So there's a whole lot of process that goes on once we know the patient is ready for transplant.
Yeah. Yeah. Of course.
Of course, and
So
then education
go
is
ahead.
education is a part of it, because we want to educate the patient, we want to educate the family. All of them needs to have a good education as to see what the outcomes are, and things
Yeah.
like that.
Yeah. Well, it seems great that you have kind of that village of doctors there helping a patient when they go through something like this. Kind of know all their options, all the steps that are going into this. So, are there any other advancements or technologies in heart transplantation that kind of gives patients better outcomes today? Could you share any insights with that with us?
Um, as you know, the as I was alluding to you before,
Yeah.
I think I'll just put some numbers in the perspective. So, um, throughout the worldwide, we do like f- close to 5,000 transplants. In
Oh,
US,
wow.
we do 2,200 transplants, right? So that's the limiting factor is the donor hearts.
Yeah.
Um, Lately, we have seen a very an uptick in the numbers for transplant because of what we have. So there is something called donation before death and donation um, after death.
Okay.
So DCD is called donation after circulated death. In the past, I mean, the first transplant was done in 1950s. When they
Mm.
did, it was like they have to declare the patient as dead. But then,
Yeah.
when ethics came in, then we said we're going to when the patient is declared brain dead, that's when we go
Yeah.
for heart testing, right? Lately, what we have seen is there is an increased donor pool with people who we get donors from after circulated death. That means that um, they don't have to be brain dead, but when they're literally after they die, we
Yeah.
harvest the organ,
Hmm.
and the transmedic device that we use to harvest that organ. So with that, I think the donor supply has gone up a little bit. So we have seen an uptick in the transplant volume over there, right?
Yeah.
Uh, the other thing that I would say is that in the past we used to use a cooler box. I mean, you go um, when we harvest the organ, we used to have a cooler box. You can get from Walmart or something, put it in an ice
Yeah.
pack and take. Now we have a Sherpa, share pack, which actually maintains the time, because you don't have much time, since by the time you take the organ out of the donor and into the recipient, it takes 4 to 5 hours. You have 4 to 5 hours of time.
Oh, wow.
So maintain that organ in that time. So the thing is how
Yeah.
to minimize the damage, right? So I think we have some of those that come up. We have what we call donation after circulated death, which increase the donor numbers. And lately, we are talking about xenotransplant, Now, it is very fairly early in the field. In 2002, I think Maryland did one xenotransplant. Patient survived for like 49 days or 47,
Wow.
47 to 49 days. But then, he died, from, I think it's a rejection or something. But I think it's a fairly new field. The reason for xenotransplant is, the pig's heart pretty much is close to human heart. I mean, the only
Yeah.
difference is like pig's heart will have a thick septum, but
Mhm.
otherwise, the size and anatomically, it's pretty much close to human heart. So there are a lot
Yeah.
of research happening there. I think they're talking about genetic knockout, so they have to make um, what it's called genetic modification. Um,
Okay.
I think the first transplant they did, the xenotransplant, they knocked out like 10 genes.
Oh, wow.
But I think
Okay.
a lot more need to be done in that field. But I think that's an exciting part that we are looking forward to.
Yeah.
Um, because if that happens, then we don't have to wait for a donor heart. I mean, um, but as you said, when the field of transplant first evolved, um, initially the uptake was very high. They did 100 transplants. People died after 9, 10 days. There was a lull
Mhm.
in the field because we were still learning things. And when cyclosporin came in, that actually changed the field. So something like that would happen where we would see more excitement in the xenotransplantation. But it's early days, but I think it's an exciting field.
That's amazing to kind of hear all the advancements in this technology and everything. Could you explain kind of like is there a higher survival rate then when people get these heart transplants? Do they typically kind of reject them, or how does that look?
So what we call in advanced heart failure, the gold standard is a heart transplant. That means that
Mm.
heart transplant is still the standard, right? So when you have advanced heart failure, you have two options. Pretty much, one is either have a mechanical heart or a transplant.
Mm.
Now, we were talking about the supply demand, right? Donor hearts are limited, right? Pumps are unlimited. Pumps have
Yeah.
their own drawback. They can provide you with stability, like someone is like really acutely getting sick and we don't have a heart. I think the pump comes in. There are some um, drawbacks to the pump because you can't do a pump if they have, like, say, a right ventricular failure or if they have infiltrative cardiomyopathies and things like that. With the pump, we have issues with driveline infections. We have bleeding, which pretty much was mitigated a lot with the new pumps that we have. Total artificial heart. There's a little bit of issue with quality of life because people say, "Oh, there's a driveline that's coming out. I need to stay on the batteries. I can't go swimming." But it's a trade-off choice. Then the other option is the transplant, which is gold standard, right? So right now, as such, we speak, 1 year survival for transplant is more than 95%. That means
Wow, that's
a
great.
person who's going to die now, if you get a heart transplant, he's going to live more than 90. There's a 95% chance that he's going to live.
Yeah.
And then the statistics goes this way, like 5 year survival is close to 70%. So
Okay.
there's a chance. And then 10 year
Yeah.
survival is 50%. And then from there on, it goes on. So I've taken care of people who have lived for 20 plus years post
Yeah.
transplant. At the same time, who had, like, 7, 8 years. So you have that gold standard. You need to take immunosuppressants. um, we have a lot more testing now to look for rejections, which we
Yeah.
didn't know 10 years ago. We we used to do frequent biopsies in the past, where we go in and take a piece of heart muscle to see if there's rejection. But right now we have a blood test that is pretty much non-invasive, that you can see a blood test and see the rejections. So the rejection rates are coming down. There is a new field evolving which is called antibody mediated rejection, which I think we are still in the process of figuring out why it happens, because sometimes these antibodies that are latent, you need to figure out what's causing the rejection and why it's happening. So that field is also growing. So I think, more all in all, if I have to put the numbers, the survival at the 10-year survival is almost 50%. That means that you have
Yeah.
50% chance to live 10 years,
Yeah, which
right?
is great. That's
Yeah.
great. Yeah. Yeah, awesome. Well, I wish we could talk about this all day because I feel like that we could really go in depth here. But as we kind of conclude, do you have any other final thoughts, any words of encouragements to maybe patients or families who are going through this right now, heart disease, heart failure? What are your final thoughts here on this conversation today?
So it's I think we have to focus more on the preventive lifestyle. I mean, you don't want to get there, right? So the focus, whoever it is, like if you're a hospital system, if you're a physician, I want them to focus on a preventive aspect of it. Right
Yeah,
now, we've seen a lot of disease of heart burden. Sorry, the burden of heart disease is
yes,
there
yeah, yeah,
because of a lifestyle. I think it's more of a lifestyle. Our eating habits, our you know lack of physical activity, all these
yeah,
cause obesity, which causes diabetes, and then you go into the spin, right?
yeah,
So I want people to focus on that. And a person who has heart failure, he needs a lot of support because it's a lifestyle change. It's a big,
yeah,
it's more or less, I would say, I would not compare it with cancer, but more like a cancer. You need a very good, robust social support system, right?
yeah,
You need somebody to encourage you. You need somebody to eat healthy. You need somebody to always remind you that, hey, keep checking your blood pressure, keep checking your weight, keep checking your, uh, going to the doctor. Like those are all the
yeah,
things. So I think that's one of the basic things that we are lacking in terms of how we can prevent. If I was a physician, I was talking to a patient, I would say, if you have a disease, if you're beyond prevention, how you can prevent from getting it worse, right? It's always
yeah,
prevention, prevention, prevention. So
yeah,
I think those that would be the focus when I sit and talk. I take a lot of time because a lot of these patients with heart failure, they are tired, they're fatigued because they deal with other aspects too. You need to have patience to deal with them. You need to talk with them. You need to have a good conversation and try to explain, um, coming down to the basics of how things can get better by
yeah,
just following the regular guidelines, right? So
yeah.
I would say that, again, the aspect of focusing on prevention is very important so that people don't have to see me, right? I mean, I'm happy
Right.
if they don't, but
I'm
if they
sure
see
they'd love
this,
to see you.
it's a trauma
Yes.
actually. A lot of people tell me when they come say, "Oh my God, you need to change the name of your heart failure. It's not heart failure," because they get scared coming to see
Yeah.
advanced heart failure is even more scary, right? So yeah.
Yeah, yeah. Well, thank you so much, Doctor. We appreciate your passion in this field, what you offer to patients, the encouragement, just the field that you're in is just amazing, and we appreciate everything that you do. We thank you for speaking with us today, and we appreciate your time. Again, feel free to reach out to us or visit our website at MyAmericanDoctor.com. But thank you so much, Doctor, for joining us today. Hope you enjoy the rest of your beautiful weekend.
All right. Thank you. You too. Thanks, Ari.
Thank
Thanks for the opportunity.
you. Talk to you later. Bye.